general dictum that early diagnosis is very important, and I think that's true for all what we do in the clinics. What do you think would be the impact of a delay in diagnosis? I mean, I'm sure you have had personal experiences where that did make a difference. If you can share some with our audience as to the timeliness of the diagnosis and the appropriate institution of the right treatment, that might kind of help everybody.
The biggest sort of impact that a patient actually feels from a delayed diagnosis is that they've just been suffering for a long time, especially the diffuse type in the hips and the knees. I mean, they can be very, very uncomfortable, and they can be in that position for a very, very long time. In the localized types, they can actually also cause pain, even though it's not necessarily all around the joint. They tend to, some of the localized types, especially in the knee or in the hip, tend to occur in very, very tight areas around those joints. And sometimes with activity, they can be really irritated. Recurrent hemarthrosis can occur. Where we get into really trouble is in the larger joints, like the knee and the hip. The recurrent hemarthrosis can actually cause joint damage and joint injury that's irreversible. And ultimately, a delay in diagnosis can significantly erode the joint to the point where somebody who could have potentially saved themselves from a joint replacement, ultimately ends up having to have one as part of their treatment. In the localized types, some of the localized types tend to be very, very large and have very, very significant involvement of the joint itself or around the joints. And sometimes those areas, low control is very difficult to achieve even with local surgery, and functionally may not do so well. So in some of those patients, you may need an amputation. It's just this recent patient we just saw who's got the localized, what appears to be in the distal first ray of the foot, with what you would consider potentially a local disease based upon its location, but very diffuse disease. The only real option there is likely going to be a ray amputation to take care of those soft tissues masses. So it can be challenging, and if you delay the diagnosis, sometimes patients, you need to escalate the patient's care beyond just surgical removal of just the tumor itself.
And inherent in that delay of diagnosis question is also the fact of, well, the wrong diagnosis, I guess, right? I think all of us treat the higher grade, more aggressive sarcomas, rare as they may be in the joint cavity. Sometimes those misdiagnoses can also be of a great deal of impact. Let me see if my medical oncology colleagues have some comments. Bob, Gina, do you want to add anything to the general discussion thus far, add to the differential diagnosis from the sarcoma medical oncologist's perspective?
I think that the main thing is you want to make sure the pathology is being reviewed by an expert pathologist. That's going to be very important because there are over 170 different types of sarcomas, and going from the benign condition to the very aggressive condition. And some of these entities can have similar features, histologically looking under the microscope, and then special staining, looking at those different antibodies, different proteins that are involved. So it's really important because you don't want to be treating a clear cell sarcoma, for example, or a synovial sarcoma as a TSGCT. So I think that that's really important, the expert pathology review.
Bob?
Yeah, those are certainly two other sarcoma diagnoses that you worry about around the knee. It's not necessarily in the joint space itself, but in the tendons around the knee. Synovial sarcoma and clear cell are up there. And then in a younger patient, we certainly see a lot of osteosarcoma around the knee and the distal femur and proximal tibia as well. So in a younger patient, that certainly comes into the diagnosis, but that should show up in those first x-rays that Dr. Abraham was talking about. So it's all part of that spectrum of the tumors we worry about that end up in our colleagues, Dr. Kim and Dr. Abraham's hands with the sarcomas about the knee.